Thank you very much. We're going to be discussing the role of venous ethanol for ablation refractory ventricular tachycardia. Why do we fail VT ablation? What do we call ablation refractory ventricular tachycardia? Most of the cases of ablation failures are due to an intramural origin of the arrhythmia substrate, whether it's VT or ventricular extrasystoles. When they come from inside the muscle, we cannot reach them. Other cases may be because they can arise from an epicardial source and the epicardium is not accessible, or because there's anatomical barriers such as the presence of a coronary artery or the His bundle. In general, what I'm going to be trying to convey today in this talk is that most arrhythmia substrates can be targeted by approaching the coronary veins. Since the coronary veins are ubiquitous in the left ventricle, and there's no portion of the left ventricle without coronary veins that cannot be reached through the coronary sinus. The coronary veins are free of atherosclerotic disease. They're free of arterial complications when we instrument the coronary veins. We have a plethora of tools for coronary sinus catheterization coming from left ventricular lead placement tools. There's no need for a tight seal when we deliver ethanol in a coronary vein as compared to coronary arteries, since any leakage that may come back, it's diluted in the coronary sinus and in the right atrium with venous blood. And perhaps more important, practically, we do not need an interventional cardiologist to come and do the case for us. We can do this venous intervention by ourselves. So veins are an opportunity for mapping and ablation of ventricular arrhythmias. I will start first with the LV summit, since this location is an area of common ablation failures where it is hard to reach from the endocardium. It is not useful to target from the epicardium. And it's where we developed our first experience with venous alcohol. The LV summit veins have been poorly characterized, and we've come up with a scheme of LV summit veins that include in an LAO caudal view an annular vein that arises from the great cardiac vein and goes along the mitral annulus. And then as the great cardiac vein becomes the anterior interventricular vein, there's septal branches as well as diagonal branches. Septal would be these veins that go deep into the septum, also called summit communicating veins, and diagonal veins will be the ones that go towards the LV. This is one example of LV summit premature ventricular complexes that were targeted through an annular vein. So again, this is a left anterior oblique view with a slight caudal inclination, where you can see the great cardiac vein, and this is the LV annular vein. It's a very, very basal vein where you can commonly record atrial signals and may have atrial branches indeed, and may communicate with the septal that follows later, as I'll show you some examples. Here we could get signals from this LV annular vein through the wire, configured as a unipolar signal. You can see very extremely early potentials in this case of PVCs, with a perfect pace map match with pacing through the wire. Alcohol in this situation was successful at eliminating tachycardia. In the bottom here, I have an example of LV annular vein that arises earlier in the great cardiac vein before the AIV takeoff, which will be here. In this case, we get a good signal from the decapolar that was placed here, but there was a septal branch right here. And then we inject contrast in the septum, we could see how it goes backwards through collateral flow into the LV annular vein, thus supporting this concept that the LV annular vein can actually communicate through collaterals with the first septals. This is an example moving forward from the coronary sinus towards the LV summit of the septal vein that arises at the very angle between the anterior interventricular vein and the great cardiac vein. In this case, we have an octopolar catheter and then a wire. The octopolar catheter can be visualized in the 3D mapping. As you can see, the earliest signal was coming from the angle between the anterior interventricular vein and the great cardiac vein, and we have the octopolar catheter going deep into that septal branch. You can see the left main coronary artery, how it is very close. Sometimes this first septal can actually go towards the RV outflow tract, and even between the left atrium and the left ventricular outflow tract. That's why sometimes it can have annular signals. This is another example where it's more clear. Just there is a common septal that arises at the angle between the great cardiac vein and the anterior ventricular vein, and those can be cannulated and can be the source of arrhythmias, as in this case, where we had a very early signal from this AIV septal with a perfect pace map, and alcohol took care of the problem. Moving forward along the anterior interventricular vein, there are first septals that can arise from the AIV proper. And this is one such example where this patient had a very tortuous great cardiac vein to AIV connection and a large septal vein where we could get a beautiful signal 40 milliseconds before the QRS and where ablation worked. This is another example of an LV summit vein in which the best signal was obtained from this tiny diagonal branch. I call diagonal here because it goes towards the side of the left ventricle as opposed to going towards the septum. And in this case, we get a beautiful signal before the QRS preceding the onset by 44 milliseconds, and ablation with alcohol took care of the problem. The interesting thing that we've been noticing in our increasing experience is that many times when you inject, that you can cannulate these septal branches and you inject contrast, you can see the staining in the myocardium on fluoroscopy. There's one example where we had a septal AIV branch where we got a beautiful signal preceding the QRS, the earliest signal. When we gave alcohol, we could see echogenicity develop in the intracardiac echocardiogram, and we could actually outline on cartosound this area of echogenicity and incorporate it into the map. And I want you to pay attention here in this map, in this view, where we have the RV outflow tract. Underneath here, the left ventricle and the left ventricular outflow tract. You can see how we had tried our best with ablation in the RV outflow tract, in the septal aspect of it. We had also ablated in the left ventricular outflow tract, trying to sandwich this area, but we were not successful. And then only when we deliver alcohol, we were able to reach this source of PVCs. And interestingly, when we outline the echogenic areas on eyes, we can see that the echogenic areas exactly match the areas in between the ablation lesions in the RV and the ablation lesions in the LV. More interestingly, we've been doing MRIs early after the alcohol delivery. And what we see is the opposite of delayed enhancement. We see what the MRI people call microvascular obstruction. And basically, we see that there's the opposite of delayed enhancement. No gadolinium at all. It gets dark. You can see how the area of microvascular occlusion can actually fill transmurally the area of the LV summit that we targeted. We have moved on the LV summit and have done a series of cases of ischemic VT, patients that had been ablated once or twice and had failed endocardial ablation of the ischemic substrate. Many of them, all of them had actually impossible epicardial access due to previous surgeries. And what we did is exploring the coronary veins. And one thing that we found, which is kind of obvious from the embryological standpoint, is that for every infarct, just as there is an infarct-related artery, there is an infarct-related vein. And one could cannulate that vein, and you can see in this 3D map the scar in the endocardium, and then a 3D map of the geometry of the coronary veins showing this vein that goes in the epicardial aspect of the scar. And we can advance the decapolar only proximal into it, so you don't see the entire geometry of the lateral vein. But when we advance a small caliper octopolar catheter as the EP star here, we can see that this catheter goes beyond the geometry, goes into the epicardial aspect of the scar. By entrainment mapping, we could demonstrate that the distal electrode was in part of the circuit with a perfect post-pacing interval, stim to QRS identical to the signal to QRS, and all those good indicators of presence in the reentrant circuit. And what we did to tackle a large area of ablation in a large epicardial vein was the double balloon technique. And the double balloon technique consists in putting two balloons in a large vein and separated by 2 centimeters, and injecting alcohol in the proximal one and let it marinate in there so that the alcohol can go into the branches that go deep into the myocardium. In our first original experience 7 years ago, we actually tried to get in individual small branches that would get us to the myocardium, but that's technically very difficult and time consuming. And the double balloon technique, by doing it in several stages, allows us to deliver alcohol in a large portion of tissue on the epicardial aspect of the scar. And when we give alcohol, we see this echogenicity develop on the epituendo scar in the intracardiac echo, showing that we can achieve a large area of epituendo ablation through alcohol in an infarct-related vein using the double balloon technique. This is another example, a patient with a previous LVAD, large inferior infarct, and you can see this posterolateral vein right on the middle of the scar. Now, this vein was huge. We were able to put, I think this was a preface sheath inside the vein, deep in the vein. We would put a decapolar catheter, use the conventional criteria of entrainment to demonstrate that the epicardium in this neighborhood of this vein was part of the VT circuit. There was nothing else to ablate endocardially. There's nothing that we could do epicardially because of the previous LVAD presence and previous cardiac surgery. We had this massive vein right on the scar, and what we did is sequentially we put the two balloons, inflated the balloons and gave alcohol, then deflated, moved them forward, gave alcohol again, and moved them forward. And sequentially we were able to deliver a large area of ablation by sequential double balloon ethanol infusion along the lateral vein that was on the epicardial aspect of a VT scar. Because the idea here is that for every infarct, there's an epicardial vein. This is yet another example of a large posterolateral infarct, big posterolateral vein. Now, in this case, the vein leaves the scar, but it has branches going down that are deep in the scar. And we were able to show extremely late activations recorded from the vein on the epicardial aspect of the scar. This is another case of an LAD infarct where we could get a multipolar catheter in the anterior interventricular vein and deliver alcohol through an angioplasty balloon. And this is one additional patient with posterolateral scar along posterolateral vein with an infarct-related vein. Now, what happens when you give alcohol in coronary veins like this? You get a large area of infarct, of ablation delivered. Every time you deliver alcohol, you can see it on the intracardiac echo. This is basal, and then we move more apical. We see the echogenicity develop. And then when we do MRI, within 48 hours, we see again this microvascular occlusion shown not as enhancement, but as dark areas of ablation created by the ethanol infusion. What happens to that microvascular occlusion? We've done a small subset of patients that had predominantly LV summit tachycardias treated with alcohol. We see in the 24 hours, within 24 hours, we see microvascular occlusion, these dark areas in several slices of the MRI, 24 hours later. But on 30 days, those areas become scarred, and then there's nothing to it. This is like any other ablation. So by creating this microvascular occlusion, we damage the capillaries, we flood that area with ethanol, and allow it to slowly become scar tissue. Overall, we have accumulated a total experience of 63 patients with ventricular arrhythmias refractory to radiofrequency in 12 centers across the world, from New Zealand to Tbilisi, Georgia, to Poland, Czech Republic, Spain, and Argentina. And Most of the patients, so 2/3 of the patients came from LV summit, had LV summit ventricular arrhythmias. 1/3 were from other areas, mostly ischemic VTs. And the approach was to map endocardial and epicardial if possible, to map the veins. And if we found a vein, we would try to cannulate it with a balloon, confirm the arrhythmogenic substrate presence in that vein, and then deliver alcohol. And with this approach, we found that out of 63 patients, 7 had no suitable veins, 56 were treated with alcohol. In 1, there was no acute effect. In the other 55, there was acute effect by alcohol. 14 of them had intraprocedural recurrence with either a change in morphology of the PVC or the VT, or the same one. With a change in morphology, we would engage in remapping and ablation, and we had 1 recurrence in those patients. With a recurrence on the same morphology, half of those eventually came back. The patients that had no intraprocedural recurrence and were treated with alcohol only, 38 were treated with alcohol only 5 recurred. Overall, freedom from ventricular arrhythmias in patients that had previous ablation failure, some of them up to 5 ablations before. We had a 76% success at 1 year with the alcohol approach. To conclude, venous alcohol can target intramural focal sources, particularly the LV summit, but also using the double balloon approach, we can target large tissue ablations in infarct-related veins for ischemic VT. Microvascular occlusion is detected on MRI acutely, and then this is replaced by scar long-term. The venous anatomy can be challenging and variable and determines the ethanol success, but it is a valuable tool for failed ablations of ventricular arrhythmias with a 76% at 1 year of follow-up. Thank you.